Vestibular schwannomas constitute about 10% of brain tumors. They are the commonest tumors of the cerebellopontine angle. They are mostly benign. A quick look at the anatomy of the cerebellopontine angle. The cerebellopontine angle is bounded by the cerebellum behind, the pons medially, and the petrous temporal bone laterally. It contains nerves. At the superior border, you have trigeminal nerve, which leaves the brainstem to enter the Doralow's canal. Quite medially, close to the brainstem, you can see the abducent nerve. The facial nerve exits from the pons and then proceeds towards the internal acoustic meatus. So does the acoustico-vestibular or the eighth nerve. Below that, in the lower margin of the CP angle, we have the lower cranial nerves. Two arteries usually course through the cerebellopontine angle. These are the superior cerebellar artery and the anterior inferior cerebellar artery. The common CP angle tumors include vestibular schwannoma, meningioma, and epidermoids. Rarer tumors, some of them which are quite dangerous and difficult to handle, include vascular malformations, glomus jugulare. Vestibular schwannomas were initially called acoustic neuromas, probably because it is easier to pronounce. The tumor arises from the acoustico-vestibular complex. However, most of the tumors, in fact, more than 90% of them, arise from the superior vestibular branch. The tumors might be just inside the internal acoustic meatus when it is called intracanalicular. Once it protrudes into the cistern, it becomes a grade 2 as per the Coos grading. When it touches the brainstem, it is considered to be grade 3, and when it distorts the brainstem, it is grade 4. The clinical features of an acoustic neuroma include the features because of nerve compromise. The commonest is because of compromise of the cochlear nerve. Patients very often present with tinnitus. They also soon have hearing loss. The vestibular component will be compromised and it will result in vertigo or imbalance. However, the severity of vertigo and imbalance is extremely variable. Facial nerve is a particularly robust nerve, though it passes through the same foramen. Usually, facial nerve compromise is not marked. However, facial nerve palsy is the commonest morbidity after acoustic neuroma surgery. The trigeminal nerve is at a distance from the acoustico-vestibular complex. However, trigeminal neuralgia may occur in these patients because a vessel might be pushed upwards to create a conflict with the trigeminal nerve and produce a trigeminal neuralgia complex. Lower cranial nerves are below, usually not affected per se by the growth of the tumor unless the tumor is very large. However, during surgery, a stretch of these nerves can result in the classical triad of dysphagia, dysphonia, and nasal regurgitation of fluids on swallowing. As an acoustic neuroma or a vestibular schwannoma increases in size, it will produce brainstem compression. This can manifest as long tract signs. Eye movements may be deranged. The CSF pathway may be blocked, resulting in hydrocephalus. This hydrocephalus may be because of the fourth ventricular compression, resulting in an obstructive hydrocephalus. Or it might be because of protein exudates from the tumor, which produce a decreased absorption of the CSF into the arachnoid granulations. Cerebellar signs may be present. and very often these patients have headache when they have large tumors. Most of these patients present with auditory symptoms. So one of the first investigations which is often done is an audiometry. Audiometry reveals a high frequency hearing loss. Here it is important to differentiate between serviceable and unserviceable hearing. If the hearing acuity is less than 50%, or if the speech discrimination score is less than 50%, the hearing is considered to be unserviceable and hearing conservation surgery may not be of much benefit. Magnetic resonance imaging will show the tumor and its relationships. A CT scan is important because it will show us pneumatization of the petrous air cells. This is important because pneumatized air cells, especially in the posterior rim of the internal acoustic meatus, may be a cause of CSF leak postoperatively if the air cells are opened during drilling of the internal acoustic meatus. The location of the cochlea is also important, again during internal acoustic meatus drilling. How do we manage an acoustic neuroma, or by the better term, vestibular schwannoma? The aims of treatment are either removal of the tumor or control of tumor growth. In small tumors, we will aim to preserve hearing. Large tumors, we want to relieve brainstem compression, and we want to control and treat the hydrocephalus. Hydrocephalus per se may be managed by a VP shunt, especially if the cause of hydrocephalus is considered to be increased proteinaceous exudates in the CSF. What are the options for management? The options for management include just observation because these tumors are benign, radiosurgery for controlling these tumors, and surgery. Which are the tumors which can be observed? Small intracanalicular tumors with a paucity of symptoms may be best left alone, observed, and followed by serial MR imaging and also by monitoring the hearing acuity. Radiosurgery provides excellent control of small tumors. In fact, tumor growth control is in the range of 95%. However, radiosurgery is associated with poor hearing preservation in these small tumors, whereas surgical removal of the small tumors may result in a higher incidence of long-term hearing preservation. Techniques of radiosurgery include gamma knife and stereotactic radiosurgery. What are the surgical options? Surgery for a vestibular schwannoma can be done by three approaches. The commonest is the retromastoid approach. Then we can do a translabyrinthine approach through the labyrinth anterior to the sigmoid sinus. And then there is a middle fossa approach where the temporal lobe is retracted and the petrous apex is drilled. Let us see the retromastoid approach. The skin and muscles are opened usually by either a lacy S, a C-shaped, or an inverted U-shaped incision. There is an option between craniectomy and craniotomy. What is important is that the initial burr hole is usually made in the angle between the transverse and the sigmoid sinus. This is important because seeing both the tentorium and the petrous at surgery helps in minimizing cerebellar retraction and in finding the extent of the tumor. Dural opening can be done by different techniques, but usually a small rim of dura is kept to protect the transverse sinus and the sigmoid, and this dura can be retracted. The rest of the dura can be covered by a wet cottonoid and used to protect the cerebellum. The first thing that we do after opening the dura is draining CSF. CSF drainage provides excellent retraction of the cerebellum. The cerebellum moves away and the pontine angle structures become obvious. Continuing with the surgical technique, arachnoid dissection is started once the tumor is seen. Arachnoid is stripped away from the tumor. This arachnoid plane is very important because most of the vessels are outside, and any vessel which is on the surface inside the arachnoid is probably a tumor vessel. So stripping the arachnoid away from a tumor helps in protecting structures inside the cerebellopontine angle. If a tumor is fairly large, an intratumoral decompression is initially done. This facilitates identification of the internal acoustic meatus. The periosteum of the petrous and the area of the acoustic meatus can be stripped away and the IAC is drilled, the posterior rim is drilled. At this juncture, the facial nerve can be identified. The tumor is teased away from the facial nerve. In a very small tumor, the cochlear nerve can also be preserved, and the tumor can be resected just by transecting the superior vestibular nerve. However, in larger tumors, separation of the cochlear nerve may not be feasible. In fairly large tumors, the lower cranial nerves will appear below the tumor or maybe even stretched below the tumor. So these are usually protected by keeping either wet gel form or a soft patty on top while dissection is in progress. On completion of tumor removal, waxing of the air cells which have been accidentally opened is important because otherwise we might end up with a CSF leak. In some cases, you can put a small fat globule and use tissue glue to seal off an opened air sinus. Dural closure is by conventional techniques, and watertight dural closure is desirable. For a quick overview, the common triad of CP-angle tumors include vestibular schwannomas, CP-angle meningiomas, and epidermoids. The tumor is benign. The aim is removal of the tumor with preservation of function. Hearing preservation is possible in small tumors. In large tumors, facial nerve function preservation becomes the challenge. Monitoring for facial nerve is desirable intraoperatively. The internal acoustic canal is drilled. Air cells which are opened during any drilling need to be waxed, and the dural closure should be watertight.